This conference is in its 10th year, and it's held annually around Valentine's Day, hence the title of the conference and the specific talks. I would like to review a few housekeeping details before introducing our speakers for today. First off, I'm Lisa Kritikos. I'm a nurse practitioner at the UCSF Memory and Aging Center, and I'll be moderating today's talk. If you have a question for our speaker, please write it in the Q&A section, which you can find by hovering your mouse at the bottom of the screen and then clicking on the Q&A button. We will have some time at the end of each speaker's talk to answer some of your questions. Please feel free to use the closed captioning feature, which you can find by clicking the CC icon at the bottom of the page. This will provide you with a live transcription of the presentation. And this talk is being recorded and will be available on the MAC, on the UCSF Memory and Aging Center and the Institution of Aging websites. And we'll put that in the chat. At the end of today's talk, we'll put a link to the course evaluation in the chat. And we welcome your constructive feedback. In order to receive CEs, participants must complete that questionnaire. It takes about 10 working days to get your CEs. And if anyone has any questions, feel free to get in touch with Caitlin Morgan if you have any questions, and we have her email address listed here. And then if you don't look at the chat at all today, don't worry, everything will be sent out in a follow-up email with everything. All right, I'd like to introduce today's speakers. So first we'll have Dr. Serggio Lanata, who's a behavioral neurologist and professor of neurology. And we have Dr. Lawren Vandevrede, also a behavioral neurologist and assistant professor of neurology. Both of them are with the UCSF Memory and Aging Center. So first we'll hear from Serggio or Dr. Lanata, and we'll have some questions after that for his talk, and then we'll move on to Dr. Vandevrede's talk and have some questions after that. So without further ado, Dr. Lanata.
Thank you, Lisa. Let me share my screen. Okay, so I'm Dr. Lanata. I'll be starting the series here with an overview of the brain, neurodegenerative diseases, and dementia. And more specifically, this is the agenda for today. A little bit about how the brain works. How does the brain change as we age? What do we mean by this term dementia? And finally, how do we evaluate persons with cognitive concerns? I'm going to touch briefly on each of these subjects. I hope I give you enough of a basis upon which we can build the rest of the series. So I want to start out by reviewing with you this concept of cerebral localization, which is really the foundation of the neurological sciences. And it basically describes the mostly precise science of predicting what regions of the brain are damaged or malfunctioning based on a careful examination of a person's signs and symptoms. In other words, the clinical syndrome that is presenting to me. And really the foundation of these principles of clinical neurological localization have a long history, and I'm not going to be able to delve into it extensively today, but I just want to highlight a little bit of it so that you understand really how is it that we know what we know about neuroscience and neurology, because I think this is really important when trying to understand Alzheimer's disease and other forms of neurodegenerative disease. And I picked to start my story in the early 1800s with this German scientist, Franz Gall, and he came up with this crazy idea that maybe by palpating the skull and getting a feel for the bumps of the skull, that maybe I can predict a person's behavior, personality, demeanor, and so forth. And this was the birth of the idea of phrenological sciences, which when you look back, really this is the foundation, let's say, of the idea that we can actually localize behavior to certain parts of the head, but not really the skull, right? The brain. But at the time, he thought that he could make predictions by palpating the skull. Obviously, empirically, this did not turn out to be true over time, but he nonetheless started this conception of localizing behavior and localizing just individual traits. Then in the mid-1800s, there was this very celebrated case. It's still studied today. It's part of probably every neuroscience course that anybody takes or psychology course. This is the case of Phineas Gage. This was an American railroad worker who suffered a horrible accident. There was an explosion, and this beam, this rod, entered his skull from the base, and it punctured out through the top of his head. And what was remarkable about this case is that he survived, and he went on to live and for many years and actually go back to work. And here you see a picture of him after the accident. And what was really illustrative of this case was that this man had, previous to this accident, been a very cordial person, very well behaved, very socially graceful. And after this accident, he really changed. But what changed was his personality and his demeanor, more than other mental functions. So it was like a very clear and well-studied a case of someone that had a focal brain injury, meaning an injury that affected only the frontal lobes of his brain, and that changed only some aspects of his behavior and thinking. So this was sort of the beginning of a scientific study of localization, really, the idea that certain parts of the brain do different things. And then we advance to the late 1800s, and we have another scientist here. This man is French, Paul Broca, and he's considered to be the father, really, of localization. He became very curious about studying people that had experienced changes in speech, changes in language, as a result of a stroke. And he did very, very detailed studies of these persons, all the way until after death, actually, meaning studying what their brains look like after death, and made these very tight correlations between what he found in the brain and the symptoms and the signs that the person had in life. And he did a link around his work to the phrenology, right? He said, well, I thought that if there ever would have been a phrenological science, it would be the phrenology of the cerebral cortex and not the phrenology of bumps on the head. And so he took that idea further and brought it to the brain. And that brings us to more recent sort of maps that we have of the brain. Here we have the work of another scientist, also German, Corbinian Brodmann, who took Broca's work further and said, well, if there is such a thing as cerebral localization, then if I look at brains physiologically, physically, I should be able to find differences between different parts of the brain in how neurons look like and how they're structured that correlate with different functions. And that's what he did, and we still use these maps today, meaning that there are differences, regional differences in how neurons and cells look like in different parts of the brain, and those differences, for the most part, correlate with very tight or functional differeces. So for example, if we look at this area here in dark, that's something we call the motor strip, meaning that these neurons, all they do is that they initiate movement on the opposite side of the body. If we look at the neurons that live in the back of the brain, the only thing these neurons do is interpret visual stimuli and so forth. And now we have a more modern view of Brodmann's map that is more functional and how different regions do different functions. Some only one function, others have shared responsibilities, let's say, in around certain aspects of cognition. And that brings us to sort of a more modern approach or a view of the brain, whereas rather than being discrete portions of the brain that do their own little thing, we have a more of an interconnected web or network of brain functions that are correlated with different regions of the brain. So this is kind of how we neurologists or people that care for persons with neurological illness think of the brain. We divide it into lobes, hemispheres, and we carry, this is a simplified map of the type of understanding that we carry around the brain as to what do different regions of the brain correlate with, what functions do different regions of the brain correlate with. And as you can see here, there are some functions, like for example, language, that are subserved by different regions of the brain. The frontal lobe, temporal lobe, and parietal lobes all have some shared responsibility to allow us to express language and understand language. Whereas other functions, like I told you before, visual processing, for example, is exclusively subserved mostly by the occipital lobe. Memory function is largely, especially short-term memory function, is largely subserved by the temporal lobe, and specifically a region called the hippocampus that we're going to return to in a moment. So this is kind of a map of how the brain works, and we use this map to understand the signs and symptoms that a person is presenting with in clinic. Now, what's also notable and interesting to neurologists is that the brain changes as we age, and as a result of the changes that we experience with aging, those functions that are subserved by the brain are also expected to change, right? So by the time we're 80 years old, brain weight or brain mass reduces 10 to 15%. Blood flow to the brain reduces by roughly 20%. The number of fibers and nerves reduces 37%. And with that, the conduction velocity of neurons also reduces as we age. So all of these can be a part of normal aging. It doesn't mean that this is an unhealthy change. And with these physiological, biological changes, as I told you before, we can expect to see functional changes across the many functions that the nervous system carries, right? So for example, if we look at ophthalmological changes, as we age, the size of our pupils reduces. We are less able to look up. So that's called restricted up gaze. That can be normal to a certain extent with aging. We become perhaps more sensitive to glare. Obviously, we experience hearing loss, especially for high pitched tones, which may affect speech discrimination. Diminution of the sense of smell can be a part of normal aging to a certain extent. Also, taste may diminish as we age. And a lot of our role as health providers is to try to distinguish how much of what I'm seeing in a person can I attribute to normal aging, and how much may go beyond age-related changes, neurological changes. Because as you can see, there's many things that can happen that can change as we age. The speed of movement, reaction time, coordination can change, sensory changes, obviously changes in gait and so forth, and also changes in cognition, as you're going to be learning today. Okay, so when we think of the brain, and when we think of brain health and the diseases, the conditions that affect the brain, it's usual to think of the substrates of the brain. When you take a deep dive into the brain, what do you find? And in a very basically, what we see, if we take a snapshot, a histological picture after magnifying many times, basically what you see are glial cells, which are these tiny cells here colored in black, or not black, but dark purple. And then you have arteries or blood vessels. This is a cross-section of an artery. And finally, you have the neurons, right, which are the brain cells that we think process information. You can see them here, different shapes, the larger ones. Basically, these are the substrates of the brain, okay? Neurons, glial cells, which are supportive cells, and blood vessels, arteries, and veins. So therefore, this is kind of how we arrange or organize the different diseases that can affect the brain, because it turns out that different categories of diseases attack different brain substrates. So for example, we have a whole family of diseases that we call cerebrovascular diseases. These are things like strokes. Obviously, they're attacking blood vessels in the brain. We have demyelinating diseases. These are diseases that primarily attack a sheath that covers neurons. And the most emblematic of these diseases would be multiple sclerosis. We have infectious diseases that really do not respect boundaries, let's say. They can attack blood vessels. They can attack glial cells and neurons, and these would be things like encephalitis and meningitis of the brain. And finally, we have, well, there's many other categories, but I want to get to this one. We have a group of diseases that we call neurodegenerative diseases. And as the name implies, this is a group of diseases that actually attack primarily neurons, and they cause degeneration of these neurons. So it's very important to understand that Alzheimer's disease is the most common form of neurodegenerative disease, but there's a bigger family of these diseases. So that's also something important to keep in mind, that there's many other different forms of neurodegenerative diseases of the brain that are not Alzheimer's disease. So for example, I'm listing a few here. We have this group of diseases called frontotemporal lobar degeneration diseases. We have Lewy body disease. We have Parkinson's disease. We have cortical basal degeneration, Huntington's disease, something called PSP or progressive supranuclear palsy, and Creutzfeldt-Jakob disease. These are all examples of neurodegenerative diseases of the brain that are different from Alzheimer's disease. However, what all of these diseases have in common as a family is that they all cause atrophy, or they all cause degeneration of neurons that leads to a reduction in brain volume beyond expected for age, right? I just told you that as we age, our brains reduce in size, but what these neurodegenerative diseases do is they accelerate that process of neurodegeneration. And as a result, people start to have signs and symptoms of a brain disease. The signs and symptoms will depend on what parts of the brain are affected the most by the neurodegenerative disease process. So here you see a healthy brain. You're looking at the left hemisphere of this brain. This would be the frontal lobe. This would be the occipital lobe. So this brain is kind of looking that way. On the opposite side of the screen, you see the right hemisphere of this brain, front and back. So that brain was looking this way. And as you can clearly see, this brain with a neurodegenerative disease has experienced a dramatic loss of volume, especially in the frontal areas of the brain, not so much in the back. So this would be an example of focal atrophy associated with a neurodegenerative disease. If we want to know specifically what disease is causing this, we have to look inside of the brain. And that's what a neuropathologist does, as I'll show you in a moment. But this atrophy that you just saw is the reason why we clinicians will get an MRI of the brain. We're trying to gauge how much atrophy is there in this person's brain, if any. So here you'll see a healthy brain, and this is what a brain with atrophy looks like on an MRI. And the way to interpret this is that we all have these fluid-filled spaces inside our brain. They're called the cerebrospinal fluid. And the idea is that whenever there is loss of brain tissue, that loss of brain tissue will be replaced by fluid. So if you look at this cut, this would be a sagittal cut, so right through the middle of the brain. You see this is all the frontal lobe of the healthy brain. Not a lot of blackness, but if you look at the top here, because there's been reduction of the brain tissue volume, that loss of brain tissue has been replaced by fluid, and therefore you see a lot of the black areas, more so than the healthy brain. Similarly here, you see that enlarged space filled with cerebrospinal fluid, which you don't see as much on the healthy brain. And also I'm highlighting the region here that has atrophy, the orbital frontal cortex, as we call it, compared to a healthy brain. And this is important because, as I told you a moment ago, different neurodegenerative diseases will attack different parts of the brain preferentially. So Alzheimer's disease has its own territory. A different disease called behavioral variant frontotemporal dementia will predominantly attack its own territories, mostly in the anterior frontal and temporal lobes. We have different types of dementia like semantic dementia, cortical basal syndrome. Each has its own preferred territory. And therefore, the clinical manifestations of each of these diseases is going to be different and recognizable. If we, like I said before, if we really want to know what is causing a neurodegenerative disease, we have to look inside of the brain. So we'll do that for this brain. We'll say that the neuropathologist finds first that there's a progressive accumulation of a protein called amyloid, or amyloid plaques, which you can see here stained in dark pink. This is one. There's another one here, another one there, here. And here we can see the amyloid plaques, not stained pink, but black. And you see them surrounding a neuron in the middle that has been stained dark black. And you see the plaque surrounding it, right? You see another plaque here and another plaque there. So that's one of the findings that the pathologist would find. And then they would also see that there's a different kind of protein that is called tau that is actually accumulating from the inside out. So it's attacking the neuron from the inside. And here you see the tau deposit inside of the neuron, stained in pink. Here you see tau that has completely taken over the neuron, and here as well. So you can imagine, right? These proteins are accumulating in this person's brain, and they're causing loss of brain tissue via degeneration of neurons, right? So when a neuropathologist sees these two proteins associated with neural loss, the neuropathologist will say, this brain has Alzheimer's disease. In other words, these two proteins are the hallmark features of our current understanding and diagnosis of Alzheimer's disease. But let's keep in mind, as I told you before, there's many other types of neurodegenerative disease. Each one of them is linked with their own pathologic hallmarks, with their own protein inclusion. So for example, this is what the protein inclusion looks like in a person who has Parkinson's disease, which is another form of neurodegenerative disease. These are what the protein inclusions look like in a person that has Lewy body disease. This is a disease that the actor Robin Williams had, which is distinct from Alzheimer's disease, and so forth. The idea that each neurodegenerative disease has its own pathological substrate, and each neurodegenerative disease, by virtue of what regions of the brain are affected, will cause its own clinical manifestation, its own clinical syndrome. And that's what I'm trying to more graphically represent here. This family of neurodegenerative diseases caused by protein aggregation in the brain lead to neurodegeneration and other pathological changes that a pathologist knows how to describe. And these physical changes lead to clinical syndromes that we can identify in clinic. When we look at Alzheimer's disease specifically, we understand today that this disease is associated with the accumulation of these proteins, as well as other pathological changes that lead to recognizable clinical syndromes. Now, what are those clinical syndromes? We're learning a lot about, we've learned a lot about the ways in which Alzheimer's disease can present itself since this disease was discovered in 1906. We've learned a lot through research. And we find that most of the times when the disease presents itself in people older than 65, people will manifest what we call typical or amnestic Alzheimer's disease. That's what AD stands for. Whereas when the disease presents itself in people that are younger than 65, that's when we tend to see Alzheimer's disease variants. In other words, same disease process, but different clinical presentation. That's where the variant word comes in. In other words, these people in early stages of the illness will not have the memory loss that we're used to thinking when we think of Alzheimer's, but will have more maybe of a visual phenomenology or visual symptoms, because this type of Alzheimer's is getting more into the back of the brain, let's say. So people will have a lot of visual processing problems, but not a lot of short-term memory loss. Whereas in this variant that we call the logopenic variant, people with this variant may present early on with a lot of issues with language expression, but really not a lot of memory loss or not a lot of visual spatial problems. We have, for instance, another variant that we call the frontal or dysexecutive variant, which affects more the front of the brain. And people are going to present not so much with memory loss or visual spatial impairment, but with changes in their behavior or their demeanor, for example. And there's other variants as well, but I'm just highlighting a few here. So let's delve a little bit into these manifestations of Alzheimer's disease. This would be the Alzheimer's disease that we're most used to hearing, right? An older adult that is having a lot of problems with short-term memory, whereas this person is able to talk to you about their remote past in a lot of detail, childhood, early adulthood. They really cannot really talk to you about recent events, like what happened earlier in the day sometimes, or just a few weeks ago. So typically they will forget, important events, details of conversations. They will tend to repeat themselves because they cannot remember that they've already, discussed a subject. They will also typically misplace belongings because they can't remember where they leave things in the immediate time frame. Over time, as the disease advances in the brain, these persons will have, other signs of cognitive impairment affecting other areas of cognition. But early on is usually mostly a problem with short-term memory. And that is because this form of Alzheimer's will typically affect a region of the brain called the hippocampus. So I told you before that this is a region that lives in the temporal lobes of the brain, and it's a region that is incredibly important for formation of new memories. So in other words, we need the hippocampi to form new memories. And what you see in this variant of Alzheimer's typically is that there's a focal atrophy of those temporal lobes, of the medial aspects of the internal aspects of the temporal lobes, which you're seeing here. These are the hippocampi, and what you would see is that there's a loss of brain tissue here that is replaced by fluid. When we're thinking of the posterior variant, which is also called posterior cortical atrophy, oftentimes, here the initial manifestations of this variant of Alzheimer's disease, which is more common in younger people, younger than 65, is not so much a impairment of recent memory, but more a problem with processing visual information. These persons do not have any trouble with their eyes per se, right? It's not an issue of them seeing blurry or seeing double. They can see fine. In fact, many times they go through several eye examinations because they're aware that something's going on with their vision, but the eye doctors keep telling them that, things are fine in your eyes. You have a minor, maybe astigmatism or something like that, but nothing severe. And that's how they often end up seeing a neurologist, because somebody says, you know what, you should see a neurologist because this could be a problem more with your brain and not so much with your eyes. These people will have significant difficulties doing things like driving, obviously, gauging depth and distance between objects. So they may be seemingly more clumsy, bumping into people, bumping into things, difficulty recognizing faces, objects, and over time, as in the other variants, other cognitive domains will be affected as well. This would be something that I could maybe show a person that I suspect has the visual variant of AD. I will show them a picture like this. I'll ask the patient to just describe what they're seeing. And you can quickly tell as a clinician that this person is having trouble integrating this picture. They cannot tell me a cohesive story of everything that's going on here. They may see for a moment that, oh, there's a woman washing the dishes, and that's all. And I take the picture out of their view, I bring it back online, and now they'll be able to capture the stool, but maybe nothing else. Or they may really be struggling to tell you what's going on because it's all kind of conflated. So that would be a little bit of what these patients may experience. And as one would expect, if you take a brain MRI of a person that has a posterior variant or posterior cortical atrophy, according to the localization principles that I outlined before, you would be very interested in looking at the back of the brain of this person. Here is the back, this is the front, this would be an axial view. And as you can see yourself, there's more cerebrospinal fluid collecting in the back of this brain than in the front. So that would be a finding that is in agreement with a clinical syndrome, right? And finally, I just want to tell you a little bit about this variant, the lobopenic variant of Alzheimer's. As I told you before, this is a variant that affects primarily language function, mostly expressive language function. So people will have a lot of difficulty getting words out. They may sound like they're stuttering. It goes far and beyond the typical word finding difficulties that most of us experience as we age, where we're in a conversation and the word that you want to say doesn't come up. This is sort of that, but magnified by 10, meaning that it's getting to the point where this person is feeling very uncomfortable even talking in public because it's happening all the time. And I'll show you a piece of this video. The patient is this man here, and you'll see the difficulties that he's having. Also through research, we've learned that in the very early stages of this variant, for reasons that we understand, people will have a lot of difficulty repeating phrases, especially long phrases. I just want to show you that this is exactly what's happening with this man, and he's very much aware of the challenge.
Can you repeat this phrase? Today was a warm and sunny day.
Today was a wonder and funny day. In some yes, it was.
Today was a warm and sunny day.
Sunday, right?
Can you repeat that again?
Yes, it was. It said that today was a sun. Was summer and.
So that's an example of the type of difficulties that persons with the lobopenic variant of Alzheimer's disease have. They can't repeat phrases. Typically, they're very aware of this difficulty to the point that it shies them away from socializing, meaning the difficulties with language expression in general. And since in the vast majority of us, regardless of what language you speak, where we come from, language function is observed by the left side of our brain, the left hemisphere, then you expect to see atrophy on the left side. This is opposite to what you see. Actually, this is the left side of the brain. This is the right side. And I think you can tell that there's more loss of brain tissue on the left side, as evidenced by the enlarged cerebrospinal fluid collection on that side. So that's a rough correlation between the clinical presentation and the brain findings. Something that we've learned that is true across the vast majority of neurodegenerative diseases is that there is a long history underlying these diseases, a long natural history. And here you're looking at the long natural history of Alzheimer's disease. So if you look at the green area here, this would be the course of the clinical course of a person with Alzheimer's. So they go from being cognitively normal to developing something we call mild cognitive impairment, to developing something we call dementia. And the point of this graph is that many years before clinical change, there are measurable changes in physiology or in pathophysiology that we can now gauge through research, meaning that we can measure the presence of the amyloid protein and the tau protein through, for example, a cerebrospinal fluid analysis, a lumbar puncture. We also have now PET scans that can allow us to measure the presence of the amyloid protein of Alzheimer's disease. And also through research, now we're testing a tau PET scan. And so the idea here is that there's physiological changes, meaning the accumulation of the amyloid protein, tau protein, and the neurodegenerative changes associated with those proteins that occur way before, years before, sometimes 5-10 years before we start to see changes on MRI, meaning the atrophy that I showed you, which in turn happens before we start to see clinical change in the person. And this is what I'm trying to capture here in a cartoon. This is just one person, let's say, that is developing Alzheimer's disease. The idea is that if I were to see this person between the 30s and 60s, and I can't, but let's imagine that I could take a piece of their brains and look at it under the microscope, I would say, you know, your brain looks fine, meaning you're going through normal age-related changes in your brain. I'm not seeing neurodegeneration. Okay, healthy brain. What we've learned through research is that a person that has Alzheimer's disease goes through an asymptomatic stage, meaning that the brain is already showing the hallmark features of Alzheimer's disease. And we can gauge that in research through spinal taps, meaning lumbar puncture, cerebrospinal fluid analysis, and PET scans and other modalities. But the person is asymptomatic, meaning that they don't have any recognizable signs or symptoms of the disease. They feel fine. Nobody's noticing anything wrong with them. And when a clinician does their MRIs and testing, everything turns out to be okay. That's an important concept, which is not a concept that is strange in the world of medicine, right? Think of a common disease like diabetes, for example. Right now, a person can have diabetes and not have any symptoms of it, right? And they get diagnosed through blood work. And there's many conditions like that, even COVID, right? Now we're learning that you can be infected with COVID but not have any symptoms. So the similar paradigm applies to neurodegenerative diseases, unfortunately. Later, this person, let's say, will enter a phase or a stage that we call subjective cognitive decline. This is when a person is already noticing that there's something changing, or maybe their spouses or a close friend is noticing change. But when they come to clinic, they're doing fine on all of our tests. MRI looks normal, cognitive testing looks normal for age, MRI looks fine. You see, so we really can't substantiate their concerns. And importantly, they're still functioning fine too, right? This is not affecting their quality of life in any way. So that's in a nutshell what subjective cognitive decline is. It can be very difficult to discern between healthy aging, meaning normal aging, and something else. It's very challenging for us. It's not until later that the person enters the stage that we call mild cognitive impairment, also called mild neurocognitive disorder in the DSM-5, And basically, this outlines a person that is having cognitive concerns that I can measure, that I can substantiate on cognitive testing, let's say, but still it's mild because it's not affecting day-to-day life in a significant way, okay? It's not until much later in the natural history of Alzheimer's disease, let's say, or any form of neurodegenerative disease, that a person reaches a stage that we call dementia, which means that things are severe, basically, right? Clearly, there's a problem. Clearly, it is interfering with day-to-day life. So we would say, my patient or this patient has dementia. And then the follow-up question would be, what is the cause? And then we would say, well, I think the cause is Alzheimer's, or I think the cause is frontotemporal lobar degeneration, or Lewy body disease, okay? So in other words, MCI, clinical state where there is mild cognitive change that is not affecting independent living in a significant way. And that's different from dementia, which is severe impairment that does significantly interfere with independent living and functional abilities. I think understanding this and keeping this in mind is very useful when we're thinking of, for all kinds of reasons, right? Researchers, for example, now are very interested in what we call primary prevention, which is what can we do here when a person is still healthy so that we can halt or prevent them from moving on to Alzheimer's disease, let's say, or any form of neurodegenerative disease. Whereas if you have a person that you're meeting in a mild cognitive impairment phase or subjective cognitive decline, what can we do at those stages so that the person doesn't advance to dementia? And that would be secondary prevention. This understanding of the natural history of neurodegenerative diseases also is very meaningful clinically. If I'm seeing a person with subjective cognitive decline or MCI, let's say, that I feel based on my assessment could be caused by Alzheimer's disease, well, the way I manage that person is going to be very different than the way I would manage a person that already has dementia caused by Alzheimer's disease. There's a world of difference that you're going to be learning about in terms of how these persons are approached. Same disease, different stage, and that's what dictates the management. Okay, so going back to this graph, the point that I want to highlight too is that all of those stages that I mentioned, subjective cognitive decline, MCI, dementia, all of these persons that have these variants, as well as a typical presentation of AD, will go through these stages progressively over time. And towards the late stages of Alzheimer's, meaning when people are already reaching dementia level of impairment, unfortunately, that's when most cognitive functions are affected. So a person that starts with, memory loss, typical AD, by the time they reach a late stage of dementia, it's not just going to be memory loss that is affected, right? It's going to be visual impairments, language, orientation, visual spatial behavior, and the same applies for these other variants. A person that starts with deficits in language over the course of years will start to have memory loss too, because the actual disease process of Alzheimer's disease moves in the brain. Those proteins and that neurodegenerative process starts to move from the temporal lobes to the frontal lobes to the parietal lobes. And that's why we see a change in the clinical presentation of the patient. And another thing that I forgot to mention is that you're going to hear about too is that going back to these stages, this understanding has also changed the way we approach drug trials, right? So in the past, we were targeting people that had dementia, but that's too late because the disease has already advanced quite a bit then. So now the shift of clinical trials, drug trials, has shifted to mild cognitive impairment and even people that are subjective cognitive decline, or even in some cases, especially people that have genetic causes of Alzheimer's, for example, or genetic causes of other diseases. Even people that are asymptomatic are now enrolling in drug trials to try to stop the disease. And you're going to learn more about that. Okay, to finish up, I want to given everything that I've told you, I would like to run you through what a diagnostic evaluation looks like, given everything I've shared. So the first step in a evaluation of a person with cognitive complaints is what we call the neurological evaluation, which is really based or rooted on our understanding of how the brain works, right? And as I showed you this image earlier, the brain is one of the reasons why the brain is unique compared to other organs of the body is that let's say that it is necessary for many different functions, right? Anything from emotional processing to memory to movement to things like balance to sensation, etc. So therefore, when you're taking a history from a person that presents to you with cognitive concerns, you can't just focus on that little on whatever the person is coming to you with. You got to expand the conversation and try to take as much information as you can from this patient. And that's what we call the history of present illness, because only through a detailed history of present illness and probing all of these areas of the brain, let's say, do we get a complete sense of what's going on in this person's brain. So we look at things like memory function. I told you about language function, what we call executive functions. These are functions that are observed mostly by the front of the brain. Things like multitasking, concentrating, judgment, problem solving, etc. We want to also ask about, your visual spatial functions, like, are you getting lost when you're driving? Are you having difficulty recognizing objects, recognizing faces, gauging depth, distance, visual processing in general? But we're also looking at, to probe how you're doing on the domain of motor functions, because sometimes these two things, cognitive changes and motor functions, can come together, and they may actually tell us what are the possible causes of the problem in general. Okay, for example, Parkinson's disease. It typically will affect the motor system, but it may also affect cognitive function. We're also interested in looking at a domain we call autonomic function and sensory changes, because sometimes these signs and symptoms are correlated with specific neurodegenerative diseases. For example, we've learned through research that diminishing sense of smell that goes beyond what we would expect for age can be linked with Parkinson's disease, for example. Same thing with constipation, that these changes can occur sometimes even 10 years before the tremor starts to happen. So there's a continuum of symptoms that are linked neuroanatomically as well. This domain of behavior, personality, emotional processing, which is also subserved largely by the frontal lobes and the anterior temporal lobes, is very important to investigate when you're seeing someone that is presenting not so much with memory loss, but with changes in personality, which is the hallmark features of a neurodegenerative disease called frontotemporal dementia, for example. And these are some of the ways that those patients can present. And then we correlate that history with the neurological exam, where we are actually probing different systems within the nervous system to see if there's a match or a correlation between what we're listening is going on, what we're perceiving is going on, and what we can objectivize is going on through our examination. And that can take anywhere from 1 hour to 3 hours, depending on the complexity of the presentation and the history. Now, an important next step in the evaluation is to have the person undergo a neuropsychological evaluation or a cognitive evaluation. Ideally, this is performed by a neuropsychologist. And the way I see this is that this would be like an independent examination of my patient, of the patient I'm seeing. Ideally, you do want a different set of eyes to look at the cognitive functioning of this person and to see if my clinical suspicion can be substantiated or not substantiated by cognitive testing. And the main goal of this testing is to compare this person's cognitive performance in relation to other people, to a group of people that are healthy, as far as anyone can tell, that are around the same age and have around the same level of education as my patient. So it gives me a more objective comparison. So I don't have to only rely on my clinical acumen and my clinical impression of my patient. So that's an important step. Once we have a clinical history, neurological examination, cognitive testing, then we move on to the third step, which would be, okay, now that I'm constructing an idea of where in the brain the problem is, I've confirmed that there's a problem cognitively based on neuropsych testing. And now I'm starting to think of, okay, what could be the causes? What is causing this? And that's where I recur to investigations. You know, you want to do blood work to make sure you're not missing something that can be causing cognitive impairment. For example, people that have severe vitamin B12 deficiencies can actually present with memory loss and cognitive impairment. So you want to check for that and other blood work as well. Then you definitely want to get brain imaging. I told you why, because we want to look to see if there's atrophy primarily, as well as other things. You know, sometimes you're surprised with tumors or signs of infection or inflammation, but we're very interested in looking at the overall volume of the brain. Then we may decide that we want to do a spinal tap to analyze that cerebrospinal fluid. As I told you before, now we are able to send a sample of that fluid to give us a readout of amyloid and tau protein. And we're hoping that over the next years, we're going to be able to analyze other proteins as well. And then we may order other tests depending on the clinical picture, like a PET scan, sleep study, etc. And that's how we define our diagnosis, okay? So based on the neurological history and examination, neuropsych testing and investigations, we already get to a point where we're saying, okay, I feel pretty confident of, you know, what is causing this. And then the fourth component to create a more complete diagnosis would be to get a good sense of how independent this person is in the presence of this illness. Right? Because that'll help me determine if I'm going to say that this person has MCI, mild cognitive impairment, or more like dementia level of impairment, or maybe something less than mild cognitive impairment. So just to run you through a quick example, very superficial, but let's say I'm seeing a person that is 57 years old, and this person comes with a 3 to 4 year history of slowly progressive impairments in visual spatial processing. They've seen many eye doctors, everything seems to be fine with their eyes, they've gone through multiple prescriptions, but they're still noticing that there's something not right with their visual processing. That's in a nutshell their complaints. And when I do my neurological examination, one of the things I see is that they have something called symbol-diagnosia, which is what I was explaining to you earlier, where I show them a picture and they're unable to integrate the picture. That together with other signs, I'm just sharing one of them. I send my patient to neuropsych testing. The neuropsychologist comes back to me and says, you know, this person clearly has visual spatial deficits far beyond expected for age and education. There's something going on. I do an MRI. I see that there's atrophy in the back of the brain. I do a PET scan. I see that there's signs of neurodegeneration also in the back of the brain. So now I have a pretty good solid suspicion for what's going on. And I say, well, I think my patient has the posterior cortical atrophy syndrome or the posterior variant of Alzheimer's disease. And then my colleague says, well, and how severe is this? I'll say, well, I think it's mild cognitive impairment because she or he is still able to function relatively well despite the challenges. Or I may say, you know, I think this is more severe. I think this is dementia level of impairment because this person can no longer drive, can no longer do their shopping, and are needing assistance all the time to go about their life, let's say. And that's basically how we arrive at this diagnosis, right? A person that has dementia caused by Alzheimer's disease that is presenting itself as the posterior variant of Alzheimer's disease. And based on that comprehensive diagnosis is that we arrive at a treatment plan and support for this person. And you're going to learn more about this, but it involves a team, basically. We have treatments that are, you know, disease specific. We have supportive treatments that are more targeting symptoms, irrespective of the cause. And then we have a whole, you know, support that we offer that is more tailored to how impaired the person is. Because as I told you before, if I'm seeing a person with Alzheimer's that is only mildly impaired, meaning mild cognitive impairment, well, the management of that person is going to be vastly different from a person that is already in dementia level of impairment. And you're going to hear more about that as we move along. And with that, I'll finish my presentation. Thank you so much for your attention and the invitation, and I'm happy to take questions.
Thank you very much, Dr. Lanata. That was incredibly interesting and very informative. We have a few good questions here. So let's start with thinking about earlier diagnosis and preventative care. Should we be attempting to establish a cognitive baseline through assessments earlier in life, for example, every 10 years, so that we can better track potential degeneration?
Great question. I think the answer is yes. We don't have, obviously there's no like statewide or national, plan to address this, but I would say that at an individual level, I think that if you are a person that for any reason are noticing cognitive changes, you may be either on the fence as to, is this just age or is it not age? I think it is a good idea to bring it up to the primary care doctor as a starting step. And because there are bedside cognitive assessments that a primary care doctor should be able to do, meaning that don't require a neuropsychologist or a trained neurologist to do. And that's always a good starting point. Try to objectivize a little bit your concerns. And there are some cutoffs that will trigger the primary care to say, you know what, this is okay, probably normal with age, or hey, you are scoring a little bit below I would expect, so why don't you go and see a neurologist, or the PCP may send you directly to a neuropsychological evaluation as a next step, right? And from that point on, things may evolve. But yes, it's important to get a baseline if you feel that you're noticing changes. There's no harm in getting a baseline.
And this sort of feeds off of that question. Are there simple self-tests for the various functions for otherwise normal older adults once they reach, say, 65 years old to identify early stages of neurodegenerative disease, sort of to be done on your own?
Yeah, great question. I am not aware of a well-validated test that can do that. I know there's many companies out there that are trying to fill that gap, but I can't talk about that with, confidence and expertise. I would caution that one thing is to screen for cognitive impairment, and another thing is to screen for neurodegenerative disease, right? So cognitive impairment refers to the clinical change. The term neurodegenerative disease refers to the cause, right? And I think it's important to understand that not everyone that has cognitive changes has neurodegenerative disease, or more specifically, not everyone that has short-term memory loss has Alzheimer's, right? I hope that came across clearly in my talk. And actually, that's the reason why you should not shy away from getting evaluated, because if you have memory problems, there's multiple potential causes for that. I mentioned briefly B12 deficiency can give you memory loss. Thyroid function abnormalities can give you memory loss, and there's other metabolic causes. So I would encourage people to just get screened and seek an evaluation if they're concerned.
Thank you. And then in a University of Washington School of Public Health study, it was noted that people who were either visually or hearing impaired had an 11% increased risk of developing dementia overall and a 10% greater risk for Alzheimer's disease specifically. But having both hearing and vision loss put individuals at a much greater risk for cognitive deterioration by as much as 86% increased risk for an all-cause dementia, more than 2 times the risk for Alzheimer's disease. Could you please speak to your own observations or research around this?
Okay. Yeah, great comment and question. I think this person is referring to, as I alluded to in my talk, the fact that we understand Alzheimer's and neurodegenerative diseases in general, for the most part, to have these long durations of illness has really shifted the attention in the minds of many researchers to try to understand risk factors. So in other words, what are the exposures or medical conditions that may put me or a population at risk of developing Alzheimer's or other causes of dementia in the future? And this person is raising some of these risk factors. Specifically, for example, large population studies have shown that indeed, when people develop hearing loss, especially starting in mid-age, and they don't address it, that becomes a risk factor for cognitive impairment or dementia late in life. But that's not the only one. There's many other modifiable factors. For example, hypertension, meaning high blood pressure, high cholesterol, diabetes, clinical depression, smoking, heavy alcohol consumption, more than 21 units, I think is the number that they're picking per week, exposure to environmental pollutants. All of these are some examples of potentially modifiable factors that, in other words, have a direct or indirect impact on our brain health and may put us at risk of Alzheimer's late in life. It is estimated that at a population level, up to 30 to 40% of cases of dementia could be potentially modifiable if we're able to modify these risk factors. So that's certainly the case, and there's a lot of research in this area and try to bring that knowledge into communities.
Let's see. And we just have a new one that came in. At times, it seems difficult for patients to access a complete neurological and neuropsychological evaluation. Can you comment on this, and how can family members, advocates help these patients access care?
Yeah, for sure. I think there's many reasons for why that's the case, all the way from lack of awareness in non-medical, just in the community, in different communities, lack of awareness. I would say awareness around brain health in general, and also it's a component around a lack of precise understanding around non-specialists, let's say, around all of these issues. That's another contributing factor, is obviously socioeconomic and other barriers. I can tell you that here in San Francisco, we've been working on this for a few years now. And the way we're approaching this is we have, aside from our clinic in the Memory and Aging Center, we also have community-based clinics. So myself and other colleagues within the Memory and Aging Center have partnered with community clinics in the Mission, in the Bayview, Hunters Point, Chinatown, for example, to try to bring our services and our clinical care into the community. So that's the whole point of having a community outreach program. But certainly there's a lot more work that needs to be done to try to mitigate all of these barriers.
And kind of switching gears a little bit, what are some of the early symptoms that often get missed or get misdiagnosed as something else?
Great question. One thing I didn't mention, and I don't mean to obviously scare anyone, right? But I think these things need to be talked about, is that, for example, we've learned that oftentimes it's quite frequent actually that persons that have Alzheimer's disease, especially, let's say, older adults, people older than 65, even before the onset of memory loss, in case of a typical presentation of Alzheimer's, sometimes years before, they will have not cognitive changes, but changes in emotional processing, or let's say emotional health. So for example, depressed mood, anxiety, irritability are things that may emerge years before short-term memory loss. So that would be an example of something that is not commonly identified as a potential prodromal signs of Alzheimer's. And that's something that we're becoming increasingly aware as we're learning through research. And there are anatomical reasons for that, why that may be the case. So that is not to say, obviously, that anyone that has depression and anxiety should be, flagged for potential Alzheimer's. But I do think that if we're seeing like a person that is older than 65 and has never had psychiatric illness or mental illness, nothing serious, and now they're having a serious depression that is not strongly linked with any life event, or they're extremely anxious or irritable, in other words, a change in their demeanor and their personality, I think we worry that those persons are not being flagged for potential neurodegenerative disease down the road. I mean, in our mind, those persons should be monitored closely. you should treat the anxiety, the depression, but in the back of your mind, keep the possibility that maybe a few years from now, this person will start to have cognitive impairment. So that would be one example. Yeah.
Yeah, very interesting. Another question. Once dementia has been diagnosed, does making lifestyle changes have any effect? And can you speak to the prednisone protocol?
Okay. I want to clarify the question, all right? Because as I told you, there's a difference between diagnosing someone with dementia and diagnosing someone with MCI, or mild cognitive impairment, or diagnosing someone with subjective cognitive decline or subjective cognitive impairment. So what we think is that, and it makes sense, right? The later you diagnose someone in the spectrum of the illness, right, chances are that they stand the least to benefit from all the knowledge that we have around what are the modifiable risk factors that influence brain health. Staying mentally active, physically active, socialization, and so forth. So I would say that, and this is a reason why it's important to try to shift the paradigm and think more of early symptoms, because chances are that that's where you have the greatest return for your investment in terms of, or even before you have symptoms, right? Taking care of your brain health. Because if you're waiting to have dementia, or if you as a provider are waiting to diagnose someone with dementia to say, oh yeah, you should be taking care of all of these things, yeah, it's better than doing nothing, obviously, but the impact is not going to be as significant, we think, compared to, starting early, when the person is healthy, informing them about what's good for their brain. When they have subjective cognitive impairment, get in there, or even MCI.
And I think with those questions, we need to move on to
Okay.
Dr. Vandevrede's talk. But thank you so much, Dr. Lanata.
My pleasure. Thank you. Bye-bye.
Are you guys able to see my slides now? And hear and see me?
Yes, we can.
Great. So first off, thank you to Lisa, Gloria, Sarah, and everyone for inviting me for this opportunity to talk to everyone about, I think, a pretty important topic, and I think that's hopeful advances in research. For anyone that doesn't know me, my name is Vandevrede. I'm an assistant professor at UCSF, and I'm in the clinical trial division, so help with our clinical trials and perform research on biomarkers, some of which we've been talking about, to try to fill the role of and need for biomarkers to diagnose these diseases earlier in the disease process. So we're working, part of my work is looking at blood tests and brief cognitive screening that we can implement more widely to diagnose people earlier. But what I've been asked to talk about today is aducanumab, which I think is a very important topic, certainly one of the biggest developments in our field in the last year, and really brings us up to the cutting edge of therapeutics, specifically disease-modifying therapeutics in Alzheimer's disease, which I'm going to be focusing on. And I've said I don't think the difficulty is talking about aducanumab, it's only talking about it for 20 minutes. And so it's a very controversial topic. There's been a lot of news out there, a lot of data. I find that patients and their families are actually quite informed about this. But the information out there isn't all of the same quality. And so I think that most discussion should start with a shared set of facts. And so that's what I'm hoping to give today, is just really look at the facts and the data of aducanumab, and then how we think about it and how it might be how it might change the future of behavioral neurology specifically, and why I think despite all the controversy, it is actually a hopeful advance in research, in my opinion. So just to piggyback on Dr. Lanata's amazing talk, I just wanted to review the real fundamentals of Alzheimer's disease pathology, because this is really basic stages that we're at in terms of investigating therapeutics. So as Dr. Lanata said, there's two proteins that we know that accumulate in Alzheimer's disease. One is called beta amyloid, that forms these sticky extracellular plaques. And one is this protein called tau that gets all these modifications and tends to clump up inside the cells. And this protein accumulation causes a cascade that makes you lose the cells in the brain called neurons, which causes all the symptoms and syndromes that Dr. Lanata detailed in his talk. And it's really thought that it probably starts with the accumulation of these proteins. And so when you're thinking, how do I treat or cure this disease? I always say, I don't think it takes, you don't have to be a genius to say, well, what happens if you get rid of these proteins from the brain now that we can identify them? And that's really what aducanumab is. It's an antibody that's designed to remove these plaques from the brain. So antibodies are proteins that are made by your immune system. They have these recognition arms that recognize antigens like a virus or a bacteria, for instance. And in this case, an antibody was designed or really discovered that recognize these amyloid plaques as harmful, and then we're able to bind to them and then signal the immune system to remove them from the brain. And so this antibody is given as an intravenous infusion into your bloodstream, where it gets into the brain in a small quantity and is able to clear these aggregates from the brain tissue. And you can see that here. This is the amyloid PET scan. The PET scan that Dr. Lanata was talking about is one of these biomarkers that we have that let us identify the Alzheimer's pathology, the neuropathology in the brain. And it's basically a radio tracer that binds and lights up if the protein is present. So everything that's red or hot here is actually amyloid aggregates that are in the brain. You can see sort of distributed throughout the brain tissue here in these two patients at baseline. And in this top patient, which was treated with placebo after a year, you see about the same amount of amyloid PET, maybe even a little bit more in certain areas, which is consistent with our understanding of the slow progressive nature of this disease. Whereas a patient here that was treated with the highest dose of aducanumab, you actually see pretty dramatic removal of this amyloid plaque from the brain. And in some cases, you can even see a complete absence of the amyloid plaque in the brain. So this is the fundamental idea of this drug. This is the hypothesis, which is it's an antibody that clears these plaques from the brain. And because we have these biomarkers, this is from early phase clinical trial, we're able to know that it did that effectively. But really, that's not the question. The question isn't, can we remove the plaques? It's, can we actually make people better? Can we prevent the development of these symptoms? Can we improve them in patients? Can we slow down the disease process? This is really the goal when we're thinking about clinical trials or treating patients. And so this was the hypothesis that was being tested in the clinical trials for aducanumab. So here's the FDA approval timeline. I think it's worth going through this in a little bit of detail because it's important in understanding this drug and how it got approved. This is a very slow process. The trials were actually developed almost 7 years ago. The readout takes 5 years, just so you have a sense of how long it can really take to test some of these hypotheses in clinical trials. That's a really long timeline. But Biogen, which is the company that made aducanumab, designed 2 phase 3 clinical trials because in early phase clinical trials, some of which I showed you that PET data, it looked like it was effective in clearing the amyloid. So they wanted to test whether it would have a clinical improvement, and the barrier for approval, FDA approval in the United States for a new therapeutic is 2 positive phase 3 clinical trials. And so they designed 2 trials called Emerge and Engage and started enrolling them. And UCSF was one of the sites that participated in the enrollment. We saw many patients through it. About halfway through or at the beginning of the trial, they changed the protocol because patients that had this particular gene, ApoE, this variant of the gene, which are known to have maybe a higher risk of Alzheimer's disease, were thought to maybe have more risk of the major side effect of this drug that I'll talk about called ARIA. And so at the beginning, they weren't given the highest dose, which ended up being the effective dose or thought to be the effective dose. But then once it was found that ARIA was well tolerated in this population, the protocol is amended and they were given a higher dose of the drug. And it's thought that this might, this protocol change is actually focused on quite a bit as explanatory for some of the later results. So just to highlight that now. Well, halfway through the trials being conducted, they did what's called an interim analysis. They look at the data that's been collected and they say, do we think that if we finish these trials out, we're going to see a positive result? And the answer based on pooling the data was they said they didn't think that they would see a positive result. So the trials were actually halted in March 2019. So myself and others had to call patients that were participating, tell them unfortunately the trial stopped. And that was the end of it. And it was thought that this was a major blow for the idea of removing the amyloid from the brain and having a positive clinical effect, really people started to move on and focus on tau and other targets that may be more potential. But there's sort of a twist in August 2019 when the rest of the data came in from the trials that hadn't yet been collected, this interim analysis. And they said, well, actually in one of the trials, in eMERGE, we actually think that there may be a signal that there's a clinical effect. And so we're going to apply to the FDA to see if we can get this drug approved. So the FDA relies quite a bit on external advisory committees. These are people like myself and others that aren't directly involved in the FDA or the pharmaceutical industry, but are willing to look at the data and give our opinion. So the advisory committee panel of 11 people voted against approval for this drug. That was their recommendation. It was that they did not think there was sufficient evidence at this time for approval. Well, the FDA extended the review, and there's this concept called accelerated approval, which is used most oftenly in cancer drugs, which is instead of focusing on an outcome that's clinical, like survival or improvement in cognition, you focus on a biomarker. So what's the change in the biomarker that we think is highly associated with those clinical data? So like in cancer, waiting for a drug to see if there's a survival benefit or not can take 10, 20, 30 years. So having a biomarker like something that lights up the drug to tells you how extensive the cancer is, they approve it based on that. It's called accelerated approval. And then they wait for the rest of the data to roll in to determine if there's a clinical effect for it to receive a full approval. So the FDA actually extended the review period and said, well, based on this amyloid biomarker data, the PET data, we're actually going to consider it for this accelerated approval pathway, which was the first. It was used in a neurodegenerative disease. And they, in June 2021, now almost a year ago, gave it conditional approval via this accelerated pathway, which was very controversial, which gives them 10 years then to run definitive trials to say whether there's actually a clinical outcome or a clinical benefit or not. And then most recently, what we saw was the drug being FDA approved, you can technically prescribe it, but it was quite costly. $56,000 a year was the initial price, though that was later cut in half. And the question, since many of our patients are over 65, is who's going to pay for this? I can't ask a patient to pay that amount of money. I think that's unconscionable. So the Center for Medicare and Medicaid Services have to make a decision on coverage. So even though it was technically available, there was no way to reimburse it. But in January, so just a couple of weeks ago, sorry, it's jumping around. In January, there was a decision that was made that it would be covered only in the context of clinical trials, so that in patients that are seen just routinely in Dr. Lanata or my clinic, this wouldn't be available for prescription, but in trials that were approved by the CMS, then the drug would be paid for through Medicare, and then for all other indications, it would be non-covered. And this was a preliminary decision. There's still 3 months before there's a final decision to be made, but as it stands right now, the drug will not have insurance coverage through Medicare or Medicaid, which often private insurers follow their example. So that's sort of the practical aspects of aducanumab. I wanted to get into the data to show you where the controversy lie, where the advisory committee concern was, and talk a little bit about the major side effects of this drug, because I think it's still potentially important, because this is only one of a class of medicines. There's actually 3 other anti-amyloid antibodies that are wending their way through the clinical trial system right now that may have a similar outcome. So I think thinking about this is really important. So this is a complicated and busy slide, but this is the biomarker results. This is why the drug was approved through the accelerated approval pathway. This is using, again, amyloid PET. And the basic idea here is these lines go over time, and they measure the amount of signal on that amyloid PET. So in this red placebo line, you can see this slight increase in amyloid PET over time. But in the patients that were given aducanumab, both the low and the high dose, you can see this biomarker effect, this real reduction in the amount of amyloid in the brain in both the eMERGE clinical trial and the ENGAGE clinical trial. And again, you can see this is just a way of graphically displaying that one patient that I saw you that had all the amyloid, the signal reduced in their brain. This is just showing on aggregate what you see in the trials, and certainly quite a dramatic effect. And this is what allowed them to achieve at least approval through the accelerated pathway. But again, what really matters is the clinical effect, not a biomarker. Biomarkers are nice if they correlate, but really, are patients getting better? This is a measure that we use. It's called the Clinical Dementia Rating Scale, where we look at different areas in life and see how people perform and how they're impacted by their disease. And basically, the higher the score, the worse the patient is. And so over time, patients will tend to get worse, albeit at a glacial pace. But in the gray line, which is the placebo line here, maybe they're getting worse at a faster rate than the patients that are treated. This little star means that there's a significant difference, at least statistically, between these two groups. And so this small difference, this change in the slope of the curve, is what we mean by disease modifying, is that these patients may be getting worse at a slower rate. Though I think it's important to say, even in this treatment arm, even at the high dose, patients still did get worse. And the difference between these two, people have said, is this significant? Is this meaningful? And I think that's an open question about the exact numbers and whether this is meaningful or noticeable to a patient. And then, very importantly, 2 points. One is this data is based on trials that were stopped. So these are data taken only from trials that were halfway completed. And in Emerge compared to Engage, there were differing results. Engage, though it showed that strong biomarker response, didn't show this clinical response. There wasn't a difference between the 3 treatment arms. And so this needs to be explained. The explanation that was given by Biogen, they said more patients in Emerge enrolled faster. So more patients actually got to the highest dose and were treated with the full dosing regimen of 14 doses at the highest dose. Again, this trial was stopped halfway. And so they said, well, Emerge was farther along. And so it was a better representation of what the clinical effect of this drug is compared to Engage, which may be true, but in my mind is kind of a hypothesis that really depends on observing what the full dosing is. Okay, so let's pivot from the clinical effects of this to one of the major side effects. I think this is important for people to understand because it's quite talked about. And the major side effect of these drugs that remove amyloid from the brain is called ARIA. ARIA is an acronym that stands for amyloid-related imaging abnormalities. So these are things we see on brain scans like MRI after treatment with drugs like aducanumab. Though you can often see some of these changes in the natural history of the disease itself, though they're quite rare in that case. And so it's a pretty name for maybe not so pretty of a thing. The ARIA comes in 2 flavors. One is swelling. These white changes in the brain are edema or water that's actually building up. This is what swelling is. And so you can see swelling in the brain, and that's called ARIA-E, which we see on this sequence. And these little speckled black spots, which are fluid, as Dr. Lanata mentioned, these little changes can also be little specks of blood that you can see, or hemorrhage or hemosiderin that you can detect in the brain. And so this is the ARIA-H. This is the little microhemorrhages. These are tiny, like the end of a pin, but this is bleeding and the swelling that you see in the brain, which happens as a consequence of the immune system removing the amyloid from the brain, because it does that by pulling it from the brain tissue into the blood vessels, and this can cause leakiness of the blood vessels, causing this edema, and sometimes can cause this hemorrhage, this ARIA-H. So this is the main consequence of amyloid related antibody treatment, and it's not uncommon. So I think this is one thing that was hit upon in a lot of coverage of this, is that this was seen actually quite frequently and seemed to happen in areas where there was clearance. So it was very much related to the actual biomarker effect, the actual removal of the amyloid from the brain, probably that were the same areas that you saw the ARIA. So it happened in about 40% of people to some level. I think this is the key point, at some level, even in very, very mild stages, even a single tiny microhemorrhage, which you can see in the context of normal disease, that was counted as ARIA, but that's okay. It's important to get a sense of how often this is happening in the disease. Oops, sorry. And again, of either type, 40% of people had it. But if you look at patients that had actual severe form of this, that was clinically significant or caused symptoms, the numbers were much lower. It was only in about 1% of people that you saw a severe form of this ARIA. But if you're talking about 1% of people treated, and you multiply this by millions of people that potentially could receive a drug, then this becomes something that you need to be very, very concerned about why it's happening and how you can prevent it from happening, and what you do if it does happen. I think these are all really important questions with these types of medicines as we're thinking about using them clinically. So again, despite being common, it's actually most often asymptomatic. We just saw it on the MRI. We'd ask the patient how they were doing. They said most often 76% of the time didn't notice it. We would do additional imaging to make sure it was stable, make the decision on whether to continue the medicine or not. But in the majority of cases, using a tightly controlled protocol with the high observation that occurs in clinical trials and the ready accessibility of a neurologist like myself, who can call you in a moment to talk about your results, it was actually managed fairly well in the context of the trial. So using these dose management strategies, the symptoms were usually mild, they were typically transient, they were self-limiting. However, I think it's really important to point out that severe cases did rarely occur. And this is even with our approach of careful patient selection, frequent monitoring, and dose management, which I'll show you in a second. So this is why it's important to still think about this, because it's hard to replicate that environment of a clinical trial out in the world once a drug gets approved. So how this gets used in sort of the average neurology clinic, I think, is something that I've thought a lot about. Just to look at the differences about patient selection, because again, patients are very carefully selected for this drug to say whether this would benefit them. As Dr. Lanata said, people are moving earlier. So as people in the mild cognitive impairment or very early dementia stage that was due to AD, due to Alzheimer's disease. We knew it was due to Alzheimer's disease because everyone had to have a biomarker. Everyone had to have a positive amyloid PET scan. And I won't get into the details of this, but these were cognitive tests and clinical measures to ensure they were all at the same stage and all had a typical sort of syndrome that was uniform that could be tracked over time. And so this was the patient population that was enrolled. This was the inclusion criteria. And anyone that had a prior brain bleed, anyone that had some of these microhemorrhages, these tiny, tiny little punctate spots before enrollment, or anyone that was on a blood thinner, a strong blood thinner, except aspirin, all of these patients were excluded. So this was really a refined and careful patient population, whereas in the FDA label, initially it was written for everyone, but fortunately they changed it to restrict it only to patients that were seen in the clinical trial, the MCI or mild dementia, and didn't really specify any clinical testing, those maybe implied that there was a biomarker. So potentially could have been more widely used than the population that was seen in the clinical trial, especially because there were no contraindications that were listed, and patients that have these risk factors like prior brain bleeds, medicines that make bleeds more likely to happen, or propensity towards showing these brain bleeds, I think may be more at risk. And so this was something I thought a lot about actually, and is why we came up with a teaching course on ARIA with the Alzheimer's Association to teach people about this and how to manage it. This is how it was managed during the trial. This is the monitoring. This is, again, just to show you how closely patients were monitored. This medicine is titrated upwards. It's built up. Each one of these is weeks. So this is each monthly infusion that you have because the drug is given once a month by IV. You slowly build it up to the target dose over the course of 6 months, and you scan them very frequently. So over the course of about 1.5 years in the clinical trial, we scanned them approximately 8 times. They had 8 MRIs. So how this would look in the clinical world with needing this many MRIs for each patient, this was, again, a question that you had to think a lot about. Certainly a baseline MRI, this is the proposal from the FDA label. They said perhaps scan them at the beginning, maybe just before they get to the dose, and maybe after they've been at the highest dose for a few months or so. Again, how we manage ARIA, this was taken from the clinical trial for patients that are asymptomatic or symptomatic. Creating these diagnostic algorithms, I think, is really important for treating physicians. So people that are maybe more or less familiar with this as an entity can have some guidance in their management of this entity if it were to arise. And so this was taken directly from our management in the clinical trial, but was effective in keeping cases often from progressing or becoming more severe, again, except in 1% of patients that were treated with the medicine. So I think that's the data that are available for aducanumab. And again, it's a drug that's FDA approved, but not covered by insurance. So technically available to be prescribed, but quite expensive, $26,000 a year, or $28,000 a year, sorry. And I think there's a lot of controversy and outstanding questions about this. I think there's concerns regarding the efficacy. We have just a couple, we don't have full phase 3 clinical trials. So does the drug even work? Does it reduce clinical progression? If it does, what's the population? Who benefits from it? My suspicion, it's going to be perhaps a fraction of patients. I think we suspect Alzheimer's is a really heterogeneous disease that maybe has a lot of different driving factors. And maybe it's only a small population of those patients that will benefit from this specific approach of removing amyloid. Maybe just people with a genetic predisposition for it that tend to accumulate this. This is all speculative. How do we extrapolate the trial data? So if we have this half of a couple phase 3s, how do we know who to give this drug to? I think this is an outstanding question. And then how will we evaluate the efficacy of this drug? How do we conduct clinical trials if there's a new drug that's available? And there's these phase 4 clinical trials, which is what you call the post-approval clinical trials that are happening. And if you have a drug that's already FDA approved and available, how do you ask somebody to enroll in a clinical trial where they may receive placebo? I think these are real challenges, not insurmountable, but challenges I think that we have to think about. How worried should we be about ARIA? What can be done to minimize the risk or treat it if it occurs? The FDA approval process, I think the accelerated approval pathway, the use of these biomarkers is still a question. Is it worth the cost? What will Medicare, will it ever revisit this decision on coverage? What can we do if additional evidence come out to suggest more benefit? Will they revise this decision? How do we ensure fair access to everyone? These are all open questions. I don't have answers for them. I have opinions on them, happy to share them. And I think a lot of this based on what's going to happen with other drugs that are in this same space. So there's 3 other medicines that do very similar things, lecanemab, donanemab, and gantenerumab, that are all anti-amyloid antibodies. And I won't belabor the point, but the results in the phase 2 trials, these are the middle trials before the phase 3, look very similar to aducanumab. The risk profile in terms of ARIA looks very similar. There's nuances, there's difference, but overall, they seem to be performing about the same. And there's phase 3 trials that are being run. These are a list of the phase 3 trials for these medicines. I think we're going to get more definitive answers in the next year or so, really about how these drugs work. And so this is what makes me hopeful, because this is the Alzheimer's drug disease pipeline. I focused on this little wedge right here, which is phase 3 disease-modifying biologics, which are to say antibodies that are designed to modify the disease. And so this is what we've talked about in this space. But there's all these disease-modifying small molecules in phase 1, 2, and 3. There's symptomatic small molecules in phase 1, 2, and 3. So this space of available clinical trials, both for symptoms and to alter the disease process, I think this is what makes me hopeful. And the fact that we might even have one that might be beginning to just bend that curve, I think this is what I get excited about. And so on the horizon, I think there's going to be more pathology targeted therapies. Tau inflammation, I think we have to think more about. What about symptomatic trials? People in the dementia stage, maybe cognitive enhancers, starting even earlier, asymptomatic patients that are biomarker positive, and maybe gene therapies like antisense oligonucleotides, maybe genome surgery. So all of these I kind of see on the horizon. And if you're interested, this is a sort of catch-all email, clinicaltrials@memory.ucsf.edu, where you can get a hold of me and the rest of the clinical trial team to discuss clinical trials that are available here at your center. I'm more than happy to talk about clinical trials that are available near you if you don't happen to be in the Bay Area, or if you just have questions, always happy to answer anyone that wants to reach out. So thank you so much for your time. Happy to answer any questions. Sorry for running up against the time limit here.
Hello. Thank you so much, Dr. Vandevrede. That was an amazing talk, and we unfortunately don't have a lot of time, so we'll get one in.
Okay.
What's the theory behind the discovery of people's brains having amyloid or tau who experienced no symptoms? Does this shift the focus of research?
I think it's an interesting question, yeah, because it's one we think about a lot here, because there's concepts of resilience and resistance, right? So the clinical syndromes don't necessarily follow directly by the amount of amyloid or tau that's in your brain. Tau is probably a little closer than amyloid, but there are people that have amyloid that show fewer symptoms or haven't yet showed symptoms. So what are the factors in those patients that actually give them resilience in the face of a burden of disease, right, the proteins? Or what are those factors in people that make them resistant to accumulating the amount of neuropathology in their brain? And they're probably genetic factors, probably lifestyle factors. I think erosion aerobic exercise is probably one of the biggest ones. But I also do think that even in those patients that show a low burden, it may be, especially with amyloid, that they might be on the road to something. That's the one that we're seeing, is that if you follow people over time, and I'm talking 10 years, 15 years, then you might start seeing some of these symptoms down the road. I think that's what the evidence that we have, and that's what's justified looking in preclinical trials in people that just have a positive amyloid PET scan that I say somehow maybe tripped and fell into a PET scanner and found out they were positive without any symptoms whatsoever. We're running clinical trials in those populations right now at the Memory and Aging Center. And so I think we'll be able to answer those questions. But I think it's certainly more questions than answers at this point.
Well, thank you very much, Dr. Vandevrede.
Sure.
And I want to thank Dr. Lanata as well. And we hope you all enjoyed the first day of our Loving Dementia Care series for this year. We'll be doing these the next 3 Tuesdays in February. And the next week on February 8th from 12:30 to 2, we're doing a talk titled Love in the Time of Dementia, where we'll hear from family caregivers and discuss early cognitive and mood changes in dementia and how this sort of affects family roles and relationships, and discuss strategies that can help. So just want to thank you all so much for joining us and for caring for patients with dementia and cognitive impairment and their families. And also just a happy